Yes. Morning. I'm just going to be introducing the speakers for the next session by Laurie. The bios go. The first one is Laurie, which we can see on the screen. She's a communications and education specialist at the Children's Institute, where she plays a central role in the production of the annual South African Child Coach and convenes the Child's Institute Child's Rights and Advocacy courses for health and allied professionals. She has a strong interest in engaged scholarship and is harnessing the power and resources of the university to promote children's rights, survival, and optimal development. Lori, do you want me to introduce everyone at the same time?
I think let's introduce each person as they come.
Yes, okay.
That would be lovely. So it's a great pleasure to be here today to share the findings from the latest South African Child Gauge, which, as you can see, is focusing on the intersections between violence against women and children. And we're doing that because we're wanting to disrupt what we see as an intergenerational cycle of harm. So what do we know about violence against women and children? We know that it's a pervasive problem in South Africa. 1 in 4 women have experienced either physical or sexual violence at the hands of their intimate partners. And 42% of our children have experienced some form of maltreatment, which could be either physical, sexual, or emotional abuse and or neglect, and again at the hands of someone that they trust, someone that should take care of them. So this is a dual challenge, and as you'll see, these two problems are deeply interconnected. What we know from the evidence is that violence against women and children tend to co-occur in the same households, and that children who experience harsh physical punishment and those who witness domestic violence between their parents and caregivers both are equally at risk of harm. The two types of violence share common risk factors and are deeply rooted in gender inequality and supported by social norms that justify men's use of violence to assert discipline and control. We also know that early exposure to violence is probably the most consistent risk factor for multiple forms of violence later in life, and that any exposure to violence has similar and compounding consequences that negatively impact on women and children's health across their life course and also drive what we call this intergenerational cycle of violence. We know that violent discipline and exposure to intimate partner violence in the home increase the risk of violence in adolescence and adulthood, with girls more likely to turn that violence inwards and to internalize it in the form of depression, suicidality, anxiety disorders. And all these things increase their risk of re-victimization, both as children and adults. Whereas boys are much more likely to externalize their early experiences of violence and express that through aggressive and risk-taking behaviors. They may struggle to form emotional connections and attachments. And again, this increases their risk of perpetrating violence in adolescence and adulthood. So the roots of both perpetration and victimization are really rooted in very often in early childhood. So what can we do to address the problem? We need to create a supportive ecosystem that brings together the whole of society to break the cycle. We need to engage with communities, with schools, to address violence within the home. And we also need to recognize that we need to start as early as possible to break that cycle, starting way back in the first 1,000 days of life. What we know is that maternal, neonatal, and child health services have the potential to intervene, to prevent violence before it starts and to prevent it from escalating further if violence has already occurred. But that is going to require an explicit focus on violence and violence prevention in the Road to Health book, in the side-by-side campaign, and in the National Integrated ECD policy. There are traces of it in all those documents, but it's not front and center of our consciousness. And if it's not front and center, we're likely to look away. We also need to recognize and extend greater support to adolescent mums. So to be thinking about violence prevention in adolescent and youth-friendly services, to support both the mum and her children, both of whom are at heightened risk for violence. And we need to build the capacity and skills of frontline health workers to identify, report, and refer mothers and children who need support. And that really requires mapping what services are available at local or district level so that we can really tighten up our referral systems so that we know who's out there. We can pick up the phone and make sure that children receive the help and support that they need. We also know that nowhere is safe for women and children. We know that men are more likely to experience violence outside the home, but that violence is more likely, women and children are more likely to experience violence in the home, in relationships of care and trust. And so there's a lot of work that we can do through parenting and family strengthening programs to build healthier relationships, to explore ways of resolving conflict without resorting to violence. But these kind of programs are only going to be effective if they work together with both men and women, and where they start to promote gender equity within the home, and in particular in the care of children. And equally important, our response services need to move beyond simply responding to the victim in front of them, and to address the broader family. So when a woman is a victim of domestic violence, we need to recognize that her children too have witnessed and been exposed to that violence, and they too are in need of counseling and support. We know that schools can serve as really powerful catalysts for change. They're a place where we can begin to promote and model the use of positive discipline in the classroom. We can challenge norms around violence. We can start to teach children the skills they need to navigate the digital world and to avoid harm, and to avoid becoming victims and or perpetrators of that harm. And schools also serve as a really important platform for identifying and supporting children who are at risk. And then once again, we need to recognize that adolescents are particularly vulnerable and in need of care and support. And that includes support in particular for pregnant teenagers and teenage mums. And that's something we've already highlighted in our discussions around malnutrition. We also need to build strong and caring communities. We need to engage the whole community, in particular political, religious, and traditional leaders who have the potential to play a really powerful role in challenging patriarchy and harmful norms, and to create safe spaces where we can have a deeper conversation around what does it mean to be a man, in ways that don't require the use of violence. So looking at the role of men as fathers, as guardians, as caregivers, and not simply seeing men and boys as part of the problem. And then we also need to support community activists in their efforts to mobilize support for survivors and to demand the delivery of better services, and to prioritize the most vulnerable groups in our society. We also know that we need to create this enabling ecosystem that includes laws and policies, leadership and coordination, finance, a healthy workforce, and data and information systems so that we can identify the hotspots and respond appropriately. And yet we know that our responses to violence against women and children tend to work in silos. And because of this, women and children fall through the cracks. We have separate funding systems, so there's competition for scarce resources, there's a lack of shared training, limited trust, and then even the data itself. Are you using different systems, different indicators? So very, very difficult to bring this puzzle together in a way that really supports both women and children. We've got good laws and policies. The key challenge is really around implementation. We know that violence against children alone is costing us up to 5% of GDP. And yet at the moment, our resources are concentrated on response services. And if we were to turn the pyramid on its head and invest more heavily in prevention, we would be able to enhance human capital, boost GDP, and reduce the costs of response services in health, social welfare, and justice. Leadership and coordination, absolutely key, but in South Africa we tend to focus on structures and we don't pay enough attention to the social dimensions of coordination, the need to build trust, and to explore what does it mean to work together in real time. And in particular to work at the intersection of violence against women and children. So thinking about the individual woman and child and how best to support both of them when violence has occurred. And to do so, we need to build the capacity of the workforce, in particular to adopt a trauma-informed approach, and to recognize, given the extent and scale of violence in South Africa, that we've all either directly experienced and or witnessed violence, and that each time that reoccurs, it triggers our own experiences of trauma. And so JP, Jean-Pierre Hartmannn, is going to talk to us a little bit more in more depth about what trauma-informed care means and how you can begin to integrate some of that in your practice. And of course, part of that trauma also impacts on you as a workforce, leading to burnout and compassion fatigue. There's very little data out there. This is SAPS data, and perhaps the most important takeaway message is that little has changed despite all our good policies and investments. Violence against children is still a scourge that affects, most homes in South Africa, and even the data that we have is limited and of poor quality. And of course, we need that data to make the problem visible. What we don't measure, we don't see, we don't invest in. So there's a strong call for better data systems so that we can target our interventions, identify those hotspots where we can also track data, not just about the child who has experienced violence, but also their relationship with their perpetrator, and what kinds of services they've been able to access. And all of those are necessary to improve both prevention and response. And last but not least, we need integrated data systems so that we can start to share data, particularly at a case management level across social services, health, and education. And so if we wish to break the cycle, the key take-home messages, we need to break the silos. We need to recognize those intersections of violence against women and children. We need to intervene as early as possible to prevent further harm. We need to embed violence prevention and response into existing systems. We can't simply be having research programs and RCTs that are here for one moment and gone the next. This work needs to be a fundamental part of the services we deliver. We need to coordinate and integrate care to respond to both the needs of women and children, to adopt a trauma-informed approach, and to ensure above all that we are including both men and women in this conversation, and to actively challenge and transform harmful gender norms. Thank you. And perhaps just to say one last thing in closing, perhaps one of the most innovative approaches featuring in the gauge is work done by Widad Slemming and colleagues up in Gauteng, where what they did is they invited men to attend the very first ultrasound scan. And what that does is it invites men to become partners, to be included as fathers in the antenatal care journey. So there's also a real question about how can we invite men in to this conversation. Thank you.
Okay, Laurie, can I go on and the next speaker? Yes, our next speaker is Fatima Khan, is the project coordinator of the Child Protection Improvement Project at the Red Cross War Memorial Children's Hospital. She qualified as a pediatrician in 2019 and brings over a decade of experience in pediatrics and academic medicine. With a strong passion for teaching, she has been actively involved in undergraduate and postgraduate training. Her professional interests lie in community pediatrics and child protection, where she is dedicated to advancing multidisciplinary care and safeguarding vulnerable children. Over to you, Fatima.
Hi guys, I hope that my screen is sharing properly, but just hi to everyone that is online. And I just want to say thank you for the Child Health Priorities Conference for inviting me to speak. And I also think that it's a great platform for us to all reaffirm our collective commitment to protecting the most vulnerable amongst us, that being women and children. And we know that we'd all echo each other's words as we go through, as violence against women and children is not just, violence against women and children is not just a social issue. It is a public health emergency. It scars the bodies and minds of communities, and if left unaddressed, it perpetuates the cycle of harm that passes from one generation to the next. So today we'll just speak a little bit about the science and the central role of the healthcare system in disrupting this cycle, and the vital role of each healthcare professional that plays in this mission. So as we know that a lot of research was done to show that the exposure to violence in childhood alters the brain development and stress responses, and even the physical outcomes later on in life. So children who have witnessed or experienced violence are more likely to suffer from anxiety, depression, and post-traumatic stress. They also have a higher risk for chronic illnesses such as heart disease, diabetes, and other due to prolonged toxic stress. And tragically, many grow up to repeat the patterns of violence they endured during the continued cycle from the previous generation. So this is not just anecdotal, it is scientifically documented. So violence leaves biological fingerprints, but science has also showed that early intervention and trauma-informed care can reverse these effects. And JP will go through a lot more about the trauma-informed care in the next session. So this is where the healthcare system becomes quite central. So as part of the central role of the healthcare system, healthcare professionals are often the first point of contact for survivors of violence. And traditionally, the health sector was seen as the responder, so generally to manage the injuries and crises. But our role is evolving as we recognize the impact of violence on our communities. So again, we are shifting towards a lot more of collaborative, intersectorial and collective efforts within our hospitals. And again, it comes down to a very multifaceted role, and one of it being the early detection and identification of recognizing the signs of abuse, whether it be physical, psychological, or behavioral. Documentation, again, the importance of accurate documentation, such as the J88, your note keeping, Form 22s, all of those, where accuracy and objectivity ensures that evidence can stand in court. And again, this comes through a lot of education and empowering our doctors and health professions from as early on in their medical career as possible. Again, the support and healing, so to provide this trauma-informed care that respects dignity and fosters resilience. Our referral and collaboration, and I think this is one part that has really come through, and it's not just collaboration within our hospitals, but collaboration outside. So from our primary and secondary levels to having good collaboration with our police officers, with our social development teams, with the Department of Education, and not just looking at it from a health perspective. Again, advocacy, so that we can use our voices to influence the policy, the challenge of harmful norms, and strengthen the child protection systems. So healthcare is not just about treating the illness, it is also breaking the cycles of harm. So this was just a highlighted slide to know that we also need early identification of, and that patients don't just present with the bruise or not just, but it is subtle changes in children's behaviors, and to see every interaction with a patient as not every, but when there is something that's not adding up in a history or something as a cry for help from the mother or the child, and to always just remember to practice with kindness, and to sometimes we are busy and we just look at what the problem is, but look at those subtle changes of sleep disturbances, new bedwetting, missing school, changing in habits, and all of those things. So what are the roles of the healthcare professionals? And this is not only directed at looking at healthcare professionals as doctors. This is looking at all of us across the board, from our allied health staff, who is also a critical part of where we say our patients are at the forefront. So what does this mean for us as individual professionals? So we are the guardians of dignity. So every patient encounters a chance to affirm safety, respect, and compassion, to make them be heard. And I think that's quite important. We also are meticulous record keeping. So again, well-documented J88s and Form 22s can make a difference between justice served and justice denied. And that must always be kept at the back of our minds. Again, we are the healers of body and mind. And I think the whole mental health and mind has come in quite strongly. And addressing trauma requires us to see beyond the physical injury and acknowledge the psychological wounds, but also knowing who within your department you have that you can call upon. And that's specific to where you work and where you practice. And then not forgetting to use the ability of seeing ourselves as educators, just educators within the community, to raise awareness so that we can empower not our families, but also empower our health professionals, empower our junior staff, empower and use every opportunity to educate. And then again, we are the disruptors of silence, where violence thrives in secrecy, and our duty is to ensure that that silence is broken, and the survivors are heard, and the system responds. So again, I'm not sure how I'm doing for time, but just in closing, that we do see that science is clear and that violence against women and children is not inevitable. It is preventable, and the healthcare system is central to prevention. We do stand at a crossroads, and we can continue to treat the symptoms of violence, or we can commit ourselves to disrupting the cycle itself. This means vigilance in our clinics, precision in our documentation, and compassion in our care, and courage in our advocacy. So let us remember, every child deserves to grow up free of fear. Every woman deserves to live with dignity, and every healthcare professional has the power to make this vision a reality. Together, through science, compassion, and commitment, we can break the intergenerational cycle of violence and build a healthier, safer future for all. Thanks.
Thank you so much, Dr. Khan. Thank you so much. You just 30 seconds over time. Just 30 seconds. Thank you so
Timed it
much.
well.
So next we're gonna have, oh my God, I hope I don't butcher this. Jean-Pierre Hartmannn I'll just call him JP because I've heard, is a clinical psychologist and is part of the Child and Adolescent Mental Health Systems Strengthening Project in the Southern Western Sub-District in Cape Town. He has a particular interest in building the capacity of frontline healthcare workers to provide trauma-informed care and in supporting children in extreme distress and those with behavioral problems. Over to you, JP. JP, over to you.
Yes, I'm just on it.
Oh, so okay.
JP, can you also put your video on?
Yes, I can.
Amazing, thank you.
Are you seeing the right presentation?
Yeah,
Yes, we are. It's all good. Lovely.
Cool. My video over here. Okay. Right, so this is just an introduction to psychological first aid and or trauma-informed care. And I just wanted to position trauma-informed care because it's a term that's used very widely, and therefore it's kind of also in many ways lost some of its real meaning. So some of what Laurie was alluding to is trauma-informed care at a sort of policy level or the procedural level, but then we can also talk about kind of the system architecture, that sometimes the fact that people have to go report at different places and the way that referrals work or don't work with DOJ or within health is not helpful. And then we also have trauma-informed care at a teams level. That's when a team operates a lot with kind of trauma, that there's a deep understanding of that fact, and that there are kind of systems in place that understand that, and there's kind of debriefing. But then really what we're talking about here, what I'm kind of focusing on, is at the individual level, at the everyday interaction between us, a doctor, a counselor, a social worker, or an allied person and a patient directly. Then there are also trauma-specific psychotherapies, which are delivered by psychologists or registered counselors. And then examples of that will be prolonged exposure or trauma-focused CBT. All right. Then I just want to position something very clearly. There's very different kinds of traumatic experiences. And so broadly speaking, we're talking about four different types: acute stress disorder, PTSD, complex trauma, and continuous stress. So the various different kinds of experiences will be classed into different categories. However, most people will first experience acute stress disorder for up to a month. And if the same symptoms stay for longer, then we can speak of post-traumatic stress disorder. And then you've got complex trauma, which is when it's when the person lives with the perpetrator. And then there's also continuous stress where there is no kind of end. It's just forever ongoing. All right. Then acute stress reaction. What this might look like in a child is that there's not wanting to talk to anybody about what really happened. The child is jumpy or on edge. They have maybe trouble sleeping, very strong emotions. They're worried about what could maybe happen. And there's some kind of big change in behavior, as well as the physical complaints. What I want to say, these are all kind of expectations. This is what we would expect of anybody that is going through difficult experience. And these are normal reactions in the beginning. So how would we approach this? It would really start with safety and calming. This has a lot to do with the sort of non-verbal and how we approach the child and really making them feel safe in that space. It's about listening with open-ended questions, really kind of finding out what are their stresses and their concerns, not kind of going into the forensics as to what happened and why, unless that's indicated. And then it's also really about validating and normalizing the traumatic reactions. So using a very plain language psychoeducation around trauma-related or stress-related signs and symptoms. And when that's done well, it almost feels like it can be very holding and containing for the child and for the family. Okay. And then we wanted to do always in the very beginning already, help the person find one or two things that they can do differently, one or two things that they can already take an action. And these are really about small steps moving into the right direction. Right? Then it's about connecting and collaborating rather than forgetting, sort of referring on and forgetting. So Laurie was speaking about kind of having a good idea of the support systems in the community and connecting patients to those and knowing how to follow up on those. Right. And then we also tend to the legal sort of reporting mandates that Fatima commented on. So these are really the sort of 6 steps of psychological first aid. Then when it comes to kind of follow-up consultations, we always reassess, kind of look what's going on, sleep, nightmare, emotional difficulties, and school functioning. Really important to kind of reintroduce sleep and daily routine, absolutely essential. And then encouraging them to, again, engage in positive activities and reconnecting with social figures in age-appropriate sort of sports settings or school activities, really doing whatever is possible to encourage that. And then also ongoing noticing of sort of physical reactions to the trauma, possibly giving medication when necessary or body-based regulation strategies. And then it's also helpful to kind of plan for school and social contexts, like helping the child feel safe in the school again. Because when the trauma initially happens, everything becomes very overwhelming, and then taking small steps to reintegrate or re-enter into the social world is essential. Okay. When working with moms, it's mostly moms, unfortunately, that is then also abuse, it is really, really important to build a good relationship with the mom. So prioritizing her safety, asking directly if there's a child abuse to also ask about the mom, and then kind of stepping very carefully around this, validating her experiences, also acknowledging the shame and the very difficult own experiences in all this, and then strengthening her sense of agency, often being able to take very small steps to get things right. We don't want to further shame and humiliate her in this kind of experience. And we want to reduce shame and isolation, so we're kind of reconnecting her with her own support system and her own network, and keeping documentation and sort of referrals very clear and neutral, because sometimes there's a sort of threats of sort of oversharing, but also being very clear about the kind of concerns of risk. And then this is a little poster thing that I will share in the chat just now. But these are things that parents can do that really can help a child find their way back quickly. So keeping things predictable and in a routine, being able to stay close and available, supporting sleep, listening to what they're experiencing without forcing it, giving reassurance, but very honestly, no sort of making things up, helping them identify their big feelings, especially in relation to what happened. And then always encouraging what was that? Anyway, keeping supportive people involved.
It was
And
the The 8-minute timer.
Oh, is that 8 minutes?
You've
Okay.
got another 2.
I was rushing to the last bit because I thought I was okay. Anyway, that's keeping supportive people involved, helping them really kind of feel safe wherever they are, and really in the time of acute stress too, we want to reduce all forms of unnecessary stress. So that sometimes means managing anxiety, managing exam time, and really just kind of slowly recovering back into normality. So I'll share this document in the chat. Or else, yeah. And then I just wanted to bring people to attention of this. This an NGO here based in Cape Town called Jelly Beans. And up until February, they have this, it's a 5 or I think 8 CPD points, and it's not many hours. It's 100 Rand, and it really kind of goes into trauma-informed care in the immediacy into a lot more detail than what's possible in these 5 minutes. Then there was one other thing I thought to just mention, considering I have more time. The different kinds of trauma. Often when we think about post-traumatic stress, that's really appropriate for medical doctors, for psychologists and counselors. The acute stress disorder is the initial presentation. Everybody that experiences something bad, including us, will have that initially. This is best helped by kind of a trauma-informed care provided by frontline staff. When we think of complex trauma or continuous traumatic stress, we, well, as frontline staff is helpful, sometimes a psychologist, but really, really important here are also other departments, and particularly social services, and kind of really thinking about the whole system of people involved in the child, that it is not just a solution that will be provided by kind of one person. It's really kind of things have to shift at a systems level in those cases. All right. Thank you.
Thank you so much. Thank you so much, JP. Thank you so much. And so what we're going to do now, I'm just going to fill the questions, and all 3 of you will come together and give answers. And I think Laurie will facilitate that program. So I will just start from the beginning. A good fellow asked, and it's a comment, said, we should ask about physical discipline of neurodiverse children when we see these children in outpatient settings. The autistic kids receive a lot of physical discipline. And I think especially in my experience, especially in PHC, most healthcare workers should be taught on how to identify, because we miss a lot of them in the PHC setting. And please feel free to comment. Okay, not this, Lord. And then Mashadi said, patriarchal mindsets is the strongest element of GPV. We need men to men-to-men trauma, men-to-men roundtables to talk about these monsters. And then I also asked, are parents always aware of the extent of a child's trauma? And do they not sometimes tend to rush recovery? And the last question was from Nozipo, who said, do you use validated trauma scales, or do you have South African specific ones, especially for children who face trauma upon trauma? Thank you. And I'll hand it over to you.
So I think most of the questions are fairly technical, so I will defer most of them to JP and Fatima, who would be best placed to answer them. I did want to respond just to the comment about men's round tables. Because whilst men are often the perpetrators of violence against women and children, it's really important for us to recognize that not all men are perpetrators. Many, many years ago, I did work with an organization called the 5 and 6 Project. And back then, we used to say that one in every 6 women was beaten or abused by her partner. And so if 1 in 6 men was a perpetrator, how do we work with the 5 and 6 so that they step up, They intervene, they challenge bad behavior. And so it's a really important question about how do we bring men into this conversation. There's a very, very nice case in the South African Child Gauge written by Malosi Langa, a psychologist from Gauteng, who's done a lot of work with boys becoming men and exploring more positive forms of masculinity. And that has been about creating a safe space where men can come together and talk and listen. But equally important, where you have positive role models that can present an alternative vision, a more positive vision of what it means to be a man. So thank you for bringing men into the conversation, Mashadi. Handing over to JP or Fatima first.
I was just going to comment about the physical discipline. I think we must just remember that corporal punishment is illegal in South Africa. Also looking at a lot of what's seen as cultural norms and all of that, just to bring in as well, because that is, and it's again, the whole intergenerational trauma that needs to be broken. Just also remember that it is reportable and that we should be, and if we also witness it, we also are then liable for reporting, because just again, remember, we are the voices of these children who don't have voices, especially the neurodiverse diverse group. We actually have a little boy who's been in our ward for, I think, almost 3 months now, because he was physically abused at home and had quite notable bruising and stuff on his body. Again, they are very vulnerable group that we do see. But yeah, that's all.
Yeah, I think to add,
go ahead.
To add to Fatima's point, also, I think with parents who beat neurodivergent kids, it's often because they don't understand the behavior. And I think kind of parenting interventions, specifically what we have now at a number of clinics in Cape Town, is caregiver skills groups, which is a WHO sort of program. And it's really about kind of helping parents understand the behavior and then responding to the behavior. Because most parents, if you ask them, does beating or hitting work, they'll say no, because the behavior in that case just gets worse and worse and worse. And then the beating can also get worse. But it's really about understanding why they do it and then responding appropriately to the behavior. And then in terms of the question of validated trauma scales, we do have a number of scales that have been validated in South Africa, although I don't think that very many people use kind of scales at least not at primary care. In the tertiary units, they are used more commonly. The thing is that when you're thinking about acute stress reaction, that's not something that you need a scale for. You can ask it and you can notice it, and that's quite observable. It's not necessary in that context. It's helpful. I mean, personally, I like having lots of scales to kind of think about, because I always think of scales as very, very clever people having spent some time, like lots of hours, thinking about exactly how to elicit certain symptoms, but then using those scales and then just asking about them directly. I'm not sure about this question. Are parents always extent of kind of in the rush for recovery? I think if I interpret the question correctly, you sometimes have something bad happened, and this is more of a longer term kind of healing process. Something bad happened to a child, and the parents really wanted to get better quickly. And that's a conversation that one has to really have, and is that this thing that happened, especially if it's kind of complex, meaning it's something that happened within the family. Because when an event is ongoing and it happens inside the family, the whole system of safety and belonging and kind of support is damaged. And especially for sexual contact or sexual abuse as part of the behavior that the child experienced, then every time they grow and they develop, especially becoming more and more independent, that old pain point will kind of reemerge in one form or another. And it's about managing that and kind of planning for it and knowing that it will come up. What also happens is for the mom and the dad or the other figures in the child's life, they feel a lot of shame and guilt about it, and that's something that also needs to be addressed very directly. I don't know how many of you here have seen the series called um, School Ties. It's a local documentary. It's on Showmax, and it's about the whole process around sexual assault and grooming, really, by teachers and so forth. And what's really helpful about it is sometimes sharing it with parents because they feel that that there's something that they themselves did wrong, and that's really, really not helpful in that kind of context. It's really kind of making the parent an ally in the recovery, almost making them like co-therapists in that entire process. All right. Yeah, and then I really do recommend people do the Jelly Beans course. It is superb. They also have a lot of other resources and sort of other training programs.
Thank you, JP. I think, yeah, what we really wanted to do with this session is to sort of go from the evidence base presented in the gauge, and then really to try and leave everyone with some practical tools and resources, so that we can go away from this session feeling a little bit more confident to intervene, and to intervene with care. I had just one other question for JP. You've talked about the need to enlist the mom and the dad and the broader family as allies in the healing process. But I was just wondering if you could talk about the ways in which child sexual abuse may trigger the mom's own experiences of
Many
violence
times.
or trauma, and how should we be responding to that as frontline workers?
So many times it does happen, and it's so unfortunate that you can really see the sort of sometimes, in one case I worked not too long ago, there was like 3 generations of sexual abuse happening again and again, and I think in that case the feelings of guilt and shame are even more extreme because what every mom tries to do is ensure that what happened to them does not happen to their kids. And then despite their best effort and despite everything else, that does not, it happens again. And it's naming and being very direct about it. But then also, there's also situations where something happened to the mom and what happened to the child was very different, but she wasn't able to really see that what happened to the child was different because her own sort of trauma is much more in the foreground. And then at times it's helpful for that parent to receive counseling and support around that, so that she is able to be there for the child in the way that the child needs. But that one really takes a sort of case by case approach to that. But and it is, I think, essential to understand that when a child has experienced trauma and they have a parent, that parent absolutely does their best, and we have to do everything that we can to really understand that parent's experience and their own experience of abuse in their history. Yeah.
So lots of circles. You have that lovely diagram with many intersecting circles of care, and it feels like it plays out in the family and then across, within the health system in teams, and then across different teams and services. But sort of tucked at the heart of all of that is this notion of care, that I think you captured so beautifully in that series of slides. So thank you.
Welcome.
Are there any last questions before we close the session?
Well, just from me, Laurie, unfortunately, Fatima is gone. Maybe JP can answer. I'm just curious because going back to what Goodfellow talked about asking questions about abuse with neurodiverse children, is there any way we can do this without sounding accusatory or sounding suspicious, especially to the parents? If you just want to find out if there's any abuse happening or...
This is a difficult one. I always I mean I always ask it directly, and especially if there's behavioral problems, because it's kind of the second step. And I mean I would ask if they've ever thought about it or if they try it. Um, and sorry, Dave's sharing the screen. So it's something that needs to be addressed very directly. If one can't sort of beat around the bush with regard. Fatima, are you back?
Oh, I don't think so.
Okay. I added
Oh,
myself on my phone because I need to just take hand over.
okay. I don't know, Fatima, if you had the question. No, I don't think so. So, Laurie, I'll hand over back to you to close off the session. I think we're done. Thank you so much, JP. Thank you, Fatima.
So thank you. Yeah, just thank you to both JP and Fatima for sharing their insights and experience, for helping to ground this session in practice. I hope everyone feels more inspired and motivated to lean in and to be there and to engage. Because we cannot afford to be silent or to look away. So thank you.
Yeah. Thanks, JP, for this PDF. It's really short, it's really simple, and so practical. I'm going to just send this out on the email this evening, just so that we've all got this in our inbox if we need it. And Fatima, if there's anything like this, any tools or little aid memoirs that you'd want to send out, please just ping that to me, and then I'll forward that onto the conference as well. Laurie, you're on mute.
Just to share the link to the jelly beans training, because I think that's the other really useful resource that JP shared.
Will do. Will do, yeah. Brilliant. Brilliant. Thanks, Laurie. Thanks, JP and Fatima. Sobering, but so important. Once again, we can't just pretend this isn't happening. This is not okay. This is something we actually need to do something about. We can't just sit in a burning house. We need to do something about this. So thank you for this call to action and giving us some real practical stuff that we can actually latch onto and take out of here. It's just gone 4 o'clock. It's been a long day. Brilliant. Thank you so much to the presenters of the first session, Nozipo and Idzani, and then the second session about child violence. Really, really impressive. Lovely afternoon. Very inspiring. Thank you very much.